about orbital disorders and ocular trauma. Your blueprint, things in bold, are what we're going to cover today. So a couple of inflammatory conditions, some corneal conditions, and then ending off with some trauma-related findings that you would see in this clinic or downrange. So before we get into the conditions, there are 3 different types of triage categories. The first one is your true ocular emergencies. These are conditions where you would need to see the patient immediately. Time is of the essence. Any delay in care will run the risk of permanent loss of vision. So there's only 4 conditions listed under true ocular emergencies. The first one is your central retinal artery occlusion. You have your chemical burns, orbital compartment syndrome, and then acute angle closure. We've gone over the central retinal artery occlusion and the angle closure glaucoma. Today, we'll go over the chemical burn and the orbital compartment syndrome. Our next triage category are urgent conditions. These are conditions that you want to see as soon as possible, preferably in the same day. Severe hyphema. So hyphema is a collection of blood in the anterior chamber. And when we have a severe version of it, it is true coverage of the iris. So the whole entire anterior chamber is filled with blood. It gives off a dark red or a black appearance, and that's why we call it the 8-ball hyphema. Severe periocular lacerations, and typically this would be your full thickness lid lacs, so lid lacerations. Orbital fracture with muscle entrapment. These patients will complain about double vision, especially if their inferior rectus muscle is trapped. Traumatic optic neuropathy, so this can either be direct or indirect injury to the optic nerve head. And then corneal foreign bodies. The last of the category is your non-urgent conditions. So the conditions listed under this would be your corneal abrasions. These are painful, like a corneal foreign body, but minus the actual foreign object in there. Your mild lacerations around the eye. The hyphemas that are not the 8-ball hyphema. Your orbital fractures that do not have any muscle entrapment, and then most of your retinal detachments. So you have different kinds of retinal detachments. We talked about it, like your regimatogenous, your exudative one, and your tractional. But when you want to break it down, you can call it a MAC on or a MAC off. MAC on is when your macula is still intact, and this is considered more of an urgent issue than, say, your MAC off. Because with your MAC on, you still have functional vision, and we want to preserve it. So these patients would normally be treated by an ophthalmologist within 24 hours. All right, so jumping into our first condition, it is preseptal cellulitis. This is an inflammation or an infection of the lid that does not go on beyond the orbital septum. This is caused by your staph and your strep bacteria. And there's usually a history of some sort of inflammation or infection. So sinusitis, some sort of local skin abrasion, a hordeolum can cause this, insect bites, or herpes simplex or varicella zoster. Symptoms are tenderness, redness, and swollen lids. Some patients will say it feels a little hot to touch. It feels a little warm. There's periorbital swelling, so it's not just the lid itself. It can involve around the eyes. In some cases, you might have mild fever. All right, so things underlying is probably important to know. The signs, you want to rule out any type of proptosis. So patients with preseptal cellulitis do not exhibit proptosis or a bulging of their eye. There is no restricted ocular motility. There is no pain on eye movement, and there is no damage or involvement of the optic nerve. So here's a picture of an example of preseptal. So the next three pictures are all from the same patient. That looks a little angrier than this one. So this upper lid is very swollen. It's going to be pretty difficult to see if there's any optic nerve involvement. Prying that lid open is probably going to induce quite a bit of pain to the patient. There's just a different view from a different angle of that swollen lid. And this is the same patient after 6 weeks of treatment. So this treatment involved excising and draining that upper lid, some hot compress, and IV antibiotics. So like I said, if this lid is really swollen and you can't look back there to rule out the proptosis and the bulging of the lid or any type of optic nerve involvement, a CT scan is usually requested. So for your mild cases, we can treat that here in family practice, active duty clinic, or in optometry. But your more severe cases, you definitely want to send them off to ophthalmology with the potential of being admitted for IV antibiotics. The dosing there that you see for your mild cellulitis or preseptal cellulitis is an adult dosing. And obviously you need to do that conversion for your peds patients. So Augmentin for about 7 to 10 days, Keflex, same thing. So moderate to severe, the way you would kind of define that or classify it is if that tissue looks like it's about to become necrotic, right? So appears toxic. Your non-compliant patients, children under the age of 5, or if there's no improvement after 48 hours of putting them on oral antibiotics. So something that looks very similar to preseptal could be an orbital cellulitis, and again, very similar history, similar cause, but this extends past the orbital septum. Right? So again, similar symptoms, but if you look at the signs now, what we said was not present in your preseptal is going to be present in your orbital cellulitis. So these patients are going to have a little bit of proptosis going on, some restriction of ocular motility, and pain with eye movement. Alright, so here's an example of orbital cellulitis. Quite a few examples. Alright, and then this one. So your workup, case history is really important, right? These patients sometimes will present after some sort of trauma or surgery. If you can open up that eye, then an assessment of the back of the eye, looking at that optic nerve, checking if there's an afferent pupillary defect, or if the patient's able to participate, then checking their color vision to see if there's any deficiency there. Right, a CT scan would be warranted for these patients to examine the orbital area and the sinuses. Some blood culture, and then lab work. Right, so this picture is the CT scan showing the proptosis and some swelling going on. Look over here, plane of the nose, this eye is bulging forward, so proptosis of right here, and then some swelling. Alright, so treatment, we're going to admit these patients to the hospital, they'll need IV antibiotics. If there is some exposure due to the proptosis, you want to do a prophylactic coverage of erythromycin ointment. And then if there's no response after a couple of days, possibly draining that abscess. Those are the only two conditions that you need to know in regards to inflammation of that lid region. The next category are retinal tumors. All right, so malignant melanoma, it's often asymptomatic. Fortunately, not very common either. Astrocytoma is a benign tumor in the central nervous system. These patients will present with leukocoria, or a white pupil. And then retinoblastoma. So rare tumor in the retina in patients under the age of 5, but within this age demographic, it is also the most common intraocular tumor. Also presents with a white pupil, and a retinoblastoma can be one eye involvement, both eyes, or you can have multiple tumors within each eye. So a lot of times, I think patients or people get confused with a white pupillary reflex versus a white pupil. So if you look at this picture, the right eye, you'll see that white small dot. That is what we would call a light reflex, right? The other eye, the whole entire pupil is white. That is leukocoria. Another example where it might not, that white might not fill up the whole entire pupil, but it's definitely present. And then looking in the eye, this is what the tumor may present like. So fortunately for me, I've only seen one case of retinoblastoma, and that was during optometry school 3rd year rotations. And I went to school in Boston, and the community health center that I was doing my rotation was in a predominantly Spanish-speaking community, and interpreters were there were very few of them for the whole entire clinic. And so it was a mom that brought in her older kiddo to pick up their glasses, and then just by chance that visit had her little munchkin, I think around the age of 2. And they were there trying to fit the glasses, adjust it, and I just happened to walk out with my patient that I just finished the exam, handing the chart over for the patient to take out their glasses. And they were just talking, and the mom was just like, I brought this up with the pediatrician, and they looked at it, and they said that it was fine, everything was fine, but like it just doesn't look normal. She was trying to describe what not normal looked like. And so the optician was just like, hey, do you mind taking a look at this patient? And so luckily I had my direct ophthalmoscope, right, on me, and I just literally shone the light on the patient. You can do a test called Bruckner test, where you open up that circular beam, and then you project that light over both eyes equally. And you're comparing that reflex and the appearance of the eye to one another, and there was definitely a leukocoria that was there. And so when I saw it, I was like, oh no, I hope it's not what I think it is. And so I went and grabbed my attending. Granted, this is not a patient that we were actually seeing, and we were kind of working through an interpreter as she was helping a different, the other kiddo. And so we ran, got the attending looked at it, and was like, I've never seen this man like reminding me of Santa Claus, right? Super cheerful, jolly, and his face turned white. He was dead serious at that point. We put in a referral, and again, a community health center, we had easy access to imaging, sent that patient off, and I think the next day, the patient was admitted. The next day, the poor munchkin was scheduled for an enucleation, so they had to remove that eye. And so again, it doesn't progress overnight to that extreme, but like I said, the mom had noticed something was going on, brought it up to the pediatrician, which is the provider you would think, because all they do is see little kids, and this is one of the most common intraocular tumors that you would find in that patient demographic, would have caught it. So one, not to be a Debbie Downer, but two, it's really important to, when you're looking at a patient, and a lot of times you're going to see normal findings, and you get into the habit of just writing, PERLA minus RAPD, or cup-to-disc ratio, 0.5. And so we want to go ahead and get into that, we get into that routine, and we sometimes forget what And so, again, when you're checking pupils, you want to look at this, right? If you see a white pupil and it's a little tiny kiddo, probably want to send this off and not tell the patient that everything looks A-okay. All right. So only 3 retinal tumors that we need to know. Retinoblastoma is the one that probably you're going to see over the other 2. Again, still pretty rare though. All right, so corneal abrasions. This for sure, super common. All right, it is usually due to some sort of mild trauma to the eye. Most common, fingernail, especially little kids reaching up and hitting their parent in the eye. A tree branch, makeup brushes, especially mascara wands, that happens a lot. They don't look scary, but man, they elicit quite a bit of pain because the cornea is highly irrigated and it picks up that pain sensation. These patients will complain about photophobia, a foreign body sensation even though there is nothing there, increased tearing, and sometimes they'll involuntarily close that eye just to make them feel better. And depending on where that abrasion is, it can cause decreased visual acuity. You're going to see some redness, sometimes a little bit of swelling of the eyelid. Definitely behind a slit lamp, you'll see that there's some epithelial defect going on. Depending on the severity of that abrasion, you may see some anterior chamber involvement, so little white blood cells floating around there. Typically, there is no discharge, even though patients will say that there is, but they're confusing it with excessive tearing. All right, so again, clarifying when they say that there is a discharge. In order to see that abrasion easier, you would put fluorescein dye into the eye. So it's this yellow dye that we use. And if there is an abrasion, it would pool in that area of defect. And immediate relief with topical anesthetics. So in the clinic, you'll find proparacaine or tetracaine. We don't prescribe this because overuse of topical anesthetic will cause what we call corneal melting. It increases the risk of a perforation of that cornea. Right, so it softens up that cornea a little too much. I know it sounds silly to write this, where it says make sure patients do not take your bottle, but it is so extremely true. This medication is the #1 medication that will grow legs and just disappear. Again, in Boston, I guess keeping the theme with the World Series, our school's clinic was probably down the street from Fenway Park, and it's situated right by MIT, Boston University, and Boston College. So when the Yankees are in town, or midterms and finals, individuals don't make smart choices. There's a lot of sports bars, a lot of bars just in general. And so hands down, we put money on it that once the Yankees are done playing or after finals exams, that you will have a patient that walks in with a corneal abrasion. Again, not smart choices, extracurricular activities. And so I remember we had 2 bottles of proparacaine that just randomly disappeared after we saw patients from different students. And the reason it being is because it provides immediate relief, right? So like I said, corneal abrasions hurt like no other. They appear very small. It's almost like that paper cut, right? It looks small, but man, oh man, that thing hurts. And because that cornea is highly irrigated. My husband ended up with a corneal abrasion because he was so extremely smart that he decided to stick his arm through these the blades, to open up the window instead of just like opening up the blinds to do that. And his arm hit the blade of it, and it got him right in the eye. And he's much bigger than I am, and to see that man just fall over, crawled into a ball, I was like, come on, dude, can't be that bad. Looked at it, he took a chunk of his cornea off. So yes, that thing hurts a lot. All right. So looking at a corneal abrasion with just normal lighting or just sitting and looking at the patient without any type of instrument, very, very difficult. And so typically we'll have the patient sit behind the slit lamp and we'll put a fluorescein dye in there and it'll highlight. So like I said, it'll pull in the area that has the epithelial defect. And made extremely easier when you click in a blue filter behind that slit lamp, and it'll highlight that area that is involved. Right, so you work up the slit lamp. You'll use a topical anesthetic. It just makes things so much easier. Patients will cooperate because they can now keep their eyes open. You'll put that fluorescein in. I don't usually measure the size of the abrasion. If there's an abrasion, there's an abrasion. That's there. Now, if it's central, then obviously we're going to treat that a little bit more aggressively because that's where the visual axis is, and we want to make sure that things heal well so that patients, after all of this is done, that they're still able to see and function. All right. You want to check for an anterior chamber reaction. So again, when we say anterior chamber reaction, we're looking for cells that's floating around in that space. And then we're looking for any type of corneal laceration or penetrating trauma. So a corneal laceration is penetrating through that cornea, right? So it's not just the epithelium that's affected. And most importantly, you want to evert that eyelid to make sure that there's nothing tucked underneath there that's causing that abrasion. All right, so for your treatment, majority of them, topical antibiotics, definitely a broad spectrum antibiotic for your abrasions from a vegetative matter, fingernail, or contact lens wear. To be honest with you, I just put them all on regardless of what the cause is. I put them on fluoroquinolone, Vigamox, or moxifloxacin, to be specific. For all others, you can put them on polytrim and trimethoprim combo. That drop stings though, and that's probably the reason why a lot of us don't use that. There's an increase in redness, tearing, burning sensation. So it's really hard for patients to want to put that in even though they know that it'll help them. Fluoroquinolones tend to be less painful on installation, and the dosing is less as well. So with your moxifloxacin, it's 3 times a day for about a week. Right, so if you have an iritis due to that trauma, you'll want to also give them a cycloplegic agent. It'll paralyze that iris sphincter, so if the iris doesn't move, it doesn't produce pain. And then eye patching, we do not patch anything from a vegetative fingernail or a contact lens cause of that abrasion. So do not patch those. Right? And then for pain, you can give them a topical or an oral NSAID. And then you'll have them come back for at least the next day, and then every couple of days until it heals. Now, if it's a really big abrasion, I probably have them come in daily just to make sure things are healing well. So just kind of a side thing, for my abrasions, the bigger ones, and especially if it's in the central part of that cornea, we will typically do what we call a bandage contact lens. And so it's a contact lens that you would normally wear. It's a soft lens, so like your Acuvue Oasis, whatever's cheap. So not like your super like crazy astigmatism contact lens. This is a lens that I know is not going to improve their vision, but it's going to keep them comfortable. And so we'll put that lens on, and so that when they do blink, their lid is not rubbing up against that abrasion, so they don't experience pain. And then the drops that we prescribe, we just tell them to put the drops in directly on top of that contact lens. About a week later, typically that's when the epithelium is fully healed, and then we'll go in and remove it ourselves. All right, lid aversions. I don't know. My kiddos now know how to do this on their own, and it's the funniest thing to run around with their lids averted. But it is a pretty simple task. You take a cotton tip applicator or a Q-tip, Place it in where that fold of the lid is. When you push down gently on that, the lid margin will roll out a little bit, and you'll want to grab the base of the lashes, so not the lash itself, because you're going to epilate the lashes, and I don't think patients will be happy with it. But you grab the base of it, and you're going to flip that over, right? You'll hold it up to make sure that there's nothing tucked underneath that lid, and then you can let the lid go, patients will blink, and then the lid will flip back down. All right, contact lens irritation. So this is usually due to some sort of trauma to the cornea from when they are putting the lens in or removing that lens. Sometimes you can get a foreign body that gets trapped underneath that contact lens. Non-compliant contact lens wearers, so if they're over-wearing their contacts or if they're sleeping in their contacts, and then if there's an improper fit of that lens. Right. So the symptoms can occur when they're wearing their contacts, when they take out their contacts, but it's usually pain with maybe a little bit of foreign body sensation that's there, a little bit of light sensitivity, some tearing, lid spasm, blurred vision, and a little bit of redness of their conjunctiva. Right, so the conjunctiva is injected, the circumlimbal area, so it's where the sclera and the cornea meets. There's a little bit of redness around that area as well. If you look at the cornea itself and look at the epithelium, there may be a little bit of defect. And so there's too tight of a lens, it can cause a little bit of a hypoxic situation for that cornea, and that cornea will swell up from it. Alright, so a closer look at a contact lens. There's no notes, I didn't make these slides, there's no notes, but looking at this lens itself, it looks like it's a pretty bad fit. You know, if we're using a hard lens, it usually is a button lens, so maybe about 3 millimeters in diameter, so it would not extend that far beyond the pupil. If we're using a lens to treat keratoconus, right, so again, another hard lens, that one is almost like the size of a quarter, so it extends beyond it. So it's probably an improper fit lens. And when that happens, under fluorescein, you can see where the lens is just touching the cornea a little bit more than you want. And so fluorescein will fill up space. And so everything that's highlighted in green is just, there's a space or a gap between the contact lens and the cornea itself. And then right dead center, there's an area of darkness, and that means that there is no space for that fluorescein to get underneath. And so that lens is actually touching that corneal surface. All right, some epithelial defect that can occur. And then pseudomonas. All right, so in the inferior portion of that cornea, there is an ulcer that is there. So pseudomonas is a gram-negative bacteria, and it's found almost everywhere. And this particular bacteria can eat away at the cornea pretty quickly. And so if a patient is not very hygienic and they just happen to touch a bunch of different things and decide to not wash their hands before they touch their contact lens, whether it is to insert that lens or to remove that lens, you can get pseudomonas on the cornea, and it can start to eat away at that epithelial surface, and then it'll just keep eating away until it perforates that cornea. And it is a quick progression, and literature says that it's usually about within 24 hours if you don't start treatment, that it could completely perforate that area. So another picture of pseudomonas on the cornea. And then acanthamoeba. Right, so acanthamoeba is a protozoan, and again, present everywhere, but most often found in hot tubs and swimming pools. And so if this gets trapped while a patient is wearing their contacts, swimming. This can happen, and this is the reason why we tell everybody, you're gonna jump into a large body of water, take your contacts out. And giant papillary conjunctivitis. So, looks scary, but out of the 3 presentations of issues that we can have with contact lenses, it's probably the least scary of them. Right? So you can get a lot of protein buildup on your contact lens, and it causes a little bit of mechanical irritation to the lining of that lid. And because it keeps constantly rubbing up against it, you form these bumps that's there. And these bumps it's almost like a suction. And so with that contact lens there and the bumps, every time you blink and it rubs up against that contact lens, it'll want to move that contact lens with the lid. And so these patients will say that their lens just don't sit very well on the eye. As far as like vision goes, they won't report of any type of blurred vision. It's just the lens moving around is not very comfortable. So with your workup, right, complete eye exam with both eyes, slit lamp exam, fluorescein to help identify some of these irritations and conditions a little bit easier. All right. When we do fluorescein, we remind patients and instruct them to take their contacts out, right? Especially the soft contact lenses, because it will permanently dye that lens yellow. Right? And again, you want to evert the lid to make sure that there's nothing tucked underneath. So if you have a patient that presents and they're complaining and you see that it's a red eye and they have a history of wearing contact lenses or they swam in their contacts, whatever it may be, I would not expect y'all to do this, right? But I would expect y'all to know who you would send this patient to. And then just kind of background information, this is what we would do for them. All right, so treatment, I'm going to remove the contact lenses. For those who are wearing the scleral lens, or the lenses that we use to treat and manage our keratoconic patients, because it's so big and it kind of hugs the eye, it's a bit harder to remove by pinching that lens in. So there's an actual suction cup that you would use, almost like a plunger, tap it onto that lens and it'll pull that lens out for you. For your GPC, so your giant papillary conjunctivitis, we would discontinue contact lens wear for at least 2 weeks. Those with the ulcers from Pseudomonas or Acanthamoeba, probably out of their contacts for a lot longer than that. All right, so if you have an abrasion, disruption to that epithelium, you want to make sure that you are covering it with a gram-negative antibiotic. Right, so Pseudomonas, scary stuff, eat through that cornea super duper quick. So you want a fortified version of your antibiotic, so meaning a higher concentration of it. And all of my Pseudomonas, I've only had 2, and they all went straight to ophthalmology. A lot of times these patients, if there's significant scarring, especially over the central part of the cornea, they'll need a corneal transplant at some point. All right, so ultraviolet keratitis. So these are individuals that experience swelling, inflammation of that cornea due to exposure of some sort of ultraviolet rays. So whether it's coming from welding or indoor tanning, and they did not wear their protective eyewear, right? You can also experience this in snowy locations, and we would call this snow blindness. There's quite a bit of pain that's associated with this, some redness, tearing, blurred vision, light sensitivity or photophobia, and then lid spasms. So just like a sunburn, right, you're out, you don't necessarily experience the full grasp of how bad it hurts until maybe the next day. So there's a delayed onset of the symptoms for these patients, usually about 6 to 12 hours. And then sometimes the pain is so bad that it'll wake the patient up at night. Right, so behind a slit lamp with fluorescein, we can see that there's pumped cornea, so little tiny dots of yellow dye. It usually is more located towards the center. Sometimes we'll get a band presentation of it because of the fact that your upper and lower lid covers part of your cornea. So those areas typically are not involved. You might have some injection, or redness, or swelling of the eyelids. So,
Did you get this from like being around a bunch of like exposed limestone? Like if you're hiking somewhere and it's a bunch of like super light rocks and it's super bright?
like off of a highly reflective surface.
I guess it's not like ultra reflective, like not like snow, but it's like pretty bright.
Mm-hmm. So I wouldn't say like in medicine there's anything that's 100% certain, right? I have not heard of it, but if it is if you're staring at that same spot for a long period of time, that there could be some type of keratitis going on. I usually see it in welders that don't wear their little mask out in the snow, or those who spend a lot of time out in the water, where that UV ray is actually bouncing off of that surface and directly into the eye, and they're out there for prolonged periods of time. I'm not too familiar with like hiking in limestone and
there's
the
like
amount of.
so there's like a spot in like Yosemite, and it's just like a bunch of like rocks, but it's like smooth rocks that are pretty bright. And I was like, this can't be good for a long time.
I mean, like I said, it probably is not if you're staring directly at it for long periods of time, but I have not seen it in literature.
But
Throw on some sunglasses.
think about it.
Sounds like we've done all.
Okay, so mild corneal edema, some injection of the conjunctiva, and maybe mild to no anterior chamber reaction. Alright, so here's an example of it, and you'll see that it tends to hover around the central part of the cornea, the superior or top and inferior portion, bottom of the cornea is pretty clear. There's a closer look at one. Work up. Right. So complete eye exam for both fluorescein makes things easier to see. Want to divert the lids and then do the case history, right? Ask about any history of welding, sun lamp use. Treatment, a cycloplegic agent to help with pain. An antibiotic ointment. Ointment stays in the eyes a little bit longer. When you do prescribe ointments, you do want to remind patients that it will affect your vision, so probably not a good idea to put that in before you decide to drive. Patching of the affected eye, and then oral medications for pain if needed. Right, so chemical injuries. So chemical injuries can cause severe vision loss, hence being a true ocular emergency. Right, you have three different types of chemicals: your alkalis, your acids, and your irritants. So alkalis, basic solutions, they tend to be more cause more harm to the eyes than acids because of the fact that it causes the proteins to denature, and then it allows further penetration of that solution into the deeper parts of the eye. So those are examples of different alkalis that you can find around readily available, as well as acids. And the symptoms that patients can experience is severe pain, definitely redness, blurred vision, lid spasms, and then obviously a history of chemical exposure. Alright, so depending on the severity of that exposure, you can experience some epithelial loss. Chemosis is a swelling of that conjunctiva, so it almost looks like there's a bubble that forms on the conjunctiva. And looking at some redness of that conjunctiva as well, subconjunctival hemorrhages, and then some involvement of the periocular skin, corneal scarring, and possibly opacification. I'd say chemical injury is pretty common. I was at Holloman prior to coming out here, training site for our F-16s and our MQ-9s. And so our F-16 maintainers with, it's like, it comes in threes, right? And so a lot of times they'll come in with hydraulic fluid in the eye or other types of stuff, and notoriously ask any of them, like, were you wearing your eye protection? They'll all say no. And so again, you'll see this. It's not an isolated situation where you read about it. It might happen. Like, these things do happen. We see patients that operate lots of heavy machinery, and it comes with that are the folks that maintain it, right? And there's a lot of different types of chemicals that they come in contact with. I wash stations at every workshop. And typically, for me, if I see a pattern, I will go out with the bioenvironmental team, as well as with flight medicine, to do an inspection. And I really just look at the eye wash station to make sure things are operating and they know how to use it. And so, with your chemical injuries, you can get that opacification of the cornea. Made the slide deck really love couple injury pictures. Yes, sir?
Just sheer curiosity, for the fresh line, it wouldn't be more acidic?
I'm sorry?
The fresh line, it wouldn't be more acidic?
Is it one of the examples? I think it's more acidic. I'll look it up during the break. Okay. This one has hypopion, so it looks like there's some white blood cells that's collecting in the anterior chamber. This is the last one. So with this one, you actually can see a little bit of chemosis going on. So looking at the conjunctiva, it's a little bit swollen, it's elevated. Looks like it's a bubble. So this area right here is elevated and it's a little bit swollen. Alright, so your workup, time is of the essence, right? And so you don't want to bother with checking pupils. You don't want to bother asking if there is, or if they're able to see the chart. You want to go ahead and start irrigating that eye. You're going to irrigate it for 30 minutes straight, steady stream. And then you're going to wait after that 30 minutes for 5 to 10, and you're going to use a litmus paper, right, and down into the impure coordinates. And then you're going to check to see if it's reached neutral. Usually on the container of the litmus paper has the color code, so we'll try to match that color code with it. Neutral 7. And if it's not neutral yet, you'll continue irrigating the eye again for 30 minutes, and then you'll just repeat checking with the litmus paper. Topical anesthetic will help where if the patient is experiencing pain. And so this way they'll keep their eyes open for you. You want to make sure you're getting underneath that eyelid as well when you're flushing out the eye. And once all of that's said and done, then you go in and start taking a look at their visual acuity, looking at their pupils, checking their pressures. So treatment, cycloplegic agent to help with pain, antibiotic ointment. You can use also oral pain meds. And then if the pressures are high, you would control that with drops and an artificial tear. says as needed, I would definitely recommend doing artificial tears on these patients. It just lubricates that cornea because it's so irritated already from that chemical exposure. And it also promotes epithelial turnover. Right, so when you guys come over to our MIF, so military instruction facility, you guys will be doing the Morgan lens, and the Morgan lens typically not done in the clinic. It's more of like a downrange out in a deployed setting. Have you guys seen what a Morgan lens looks like? Yeah? No? Okay, so it looks like a contact lens that's attached to a bag of saline. Alright, so if you're a contact lens wearer, and I'm pretty sure Major Hyden will remind you all that I would probably take your contact lenses out before coming over. But yeah, so we'll have different stations. Our enlisted instructors will kind of walk you guys through it, and I believe you all are going to perform Morgan lens on each other. Yeah, there's plenty of Morgan lens over there. I think they're all really excited for you guys to head on over. Alright. Any questions so far? Alright, so let's go ahead and take a 10-minute break and then pick up with core body.
I just went back and I had a catheter on there.
We're in Europe, and one of the tracks broke down. Like, it's like the same thing when they did like doctors separated, so they couldn't get for hours. So with my my smoke, so we drive around to go check on them, and we just see smoke and like the track cat was on fire. So the guys were on fire. It was like 30 degrees out.
Good for them. Talk about like the elevated maps.
Yeah.
She basically said like everything's elevated. But when I looked it up, it said heart failure is only elevated in and then AMI is everything. The CK, the iron globulin.
Yeah, so you think that one is going to be your for MI. So in that case, she could give you one of the other. She could give you labs, and it's going to either have an elevated EMT or elevated MI.
It's by what you were doing.
Just look for look for BMP and look for protein, and those are going to tell you yeah.
Is that the myo?
Yeah, that thing. Yeah, like the big one.
I got asked out on the date side. I got somebody.
I thought you said you were to go.
This guy's been asking me about
Give him a chance. You never know. That could be the one.
he's actually funny. He's not going to be funny. It's just hard to date. I would say, yeah, ask him to like, it's always nice. Just since it's not so
Huh?
You guys want candy?
Oh,
I think I'll just take it, you know.
got hard. Class, every test class, so it's like, yeah, it's something. I have a 97 right now. I need a 225.
Wow.
I need a 31. I need a 31 next to. Divided by 2. I need 15. My low is red. Done.
I'm like that.
I have made my
Hi. I don't know. I probably. Is it chocolate? Well, if it's you, then there you go.
Like that's why I got it. That's why I thought of it. You know how they have like those
You know about the hard caramels? Yes. The Werther's? Apnea.
Caramel chocolate. Almond in there. Like a healthy snack.
Almond in there.
Because almonds are healthier than peanuts.
Pretty sure almonds have more calories. Almonds are very high caloric. Makes themselves high caloric.
Yeah. They have more fiber.
Almond versus.
He cried for a week.
So it beats by 6 calories. The almond.
That was so funny.
Our eating has nuts for fiber. A lot more fiber than
That one is my, it is my favorite. Honestly, it is my favorite. I like artists. It's like,
almond has a little bit more fiber, but has more carbs. It has more. No, has more protein. It has more fat. Who's actually healthier? Who's actually healthier now?
there's a receipt on your feet. So you do some dice, like a swap. And then when you roll the dice, you roll the dice.
Frostbite. Just sit out there. Like, look at that, doing all that.
Yeah, but stuff all the out, and it's gonna bypass this to the classroom, and it's gonna freeze them out.
And
At our home, and like,
look how much air is there. You can see it from that best.
oh, that one, it has a little fancy. Oh, that black ball, just
For white mold.
I prefer yellow mold.
We're having a black.
It's a yellow mold.
Have you ever tried lead paint?
Delicious chip on it. Yeah, they only give you partial pH for that.
They give you $500.
That was your lead paint bonus. It's like, hey, we're sorry that you're gonna have issues, but $500.
Science is way better than
I never signed that in my life.
Well, yours
I saw the sign the lead paint thing, but then it said only in older housing. But I tried to sign it. So.
yours are like literally nothing.
No, they're super nice. When I was first moving, they signed the lead paint away from me.
They should probably do it.
They're like, right.
I'm a fatty.
Derek?
Yeah.
What are we doing
He always says it after he gets
That's how you lay something fat.
his notes on it.
No. Take this shit off my own.
Wait, you're gonna go on the date or no?
0 minutes.
Summer today?
Okay, so let's finish up with the cornea with corneal foreign body. Right, so these patients will complain that they feel like there's something in their eye. It'll induce tearing, redness, ocular irritation, maybe with some pain, depending on pain tolerance. Foreign bodies due to a low velocity, right? So say like working under a car, that foreign body tends to be a little bit more superficial versus something that comes at the eye at a higher velocity, and that tends to go deeper into the cornea. Patients will experience some redness of their conjunctiva, maybe a laceration. Sometimes the foreign body is not visible, and so you may need to evert that upper eyelid and take a look at that lower eyelid as well. And then for some, the subconjunctival hemorrhage may be present. Alright, so here's a picture of a corneal foreign body. Another one. Now if it's metal foreign body, you worry about a rust ring, and so you really do want to remove that foreign body as soon as possible. I've seen cases where it's only a few hours and rust starts to develop on that cornea. So with a superficial foreign body, you can go in with a cotton tip applicator, anesthetize the eye first, right, and then just gently sweep over that, and a lot of times it'll pick it right up. Something that's a little bit deeper, you might need a little bit of a sharp edge, and so I tend to use like a 16 gauge or an 18 gauge needle, using that bevel as a help to help kind of sweep that foreign body out. And if there is a little bit of a rust ring, we do have what we call an algae brush. It is a battery operated brush that kind of just basically sloughs off that epithelium. Alright, this is a tracking presentation, so there is not a foreign body directly in the eye, but it's leaving a mark on the cornea. And so that is the reason why you want to evert that lid. This is a different example, but in that lower right corner, you'll see these little line markings on the cornea, easier to see with fluorescein dye. And you don't see a foreign body there, but if you evert that upper lid, you'll see that little tiny speck that's wedged right up in there. So right here. So basically, whenever the patient moves their eye or they blink, that little piece that is wedged up there is scratching that corneal surface. Conjunctival foreign body, so now that foreign body is on the conjunctiva. So your workup, we're going to do a visual acuity beforehand. We're going to take a look at the eyes. If you're suspecting that there's an intraocular foreign body, you want to dilate that patient and check that IOP, so their intraocular pressure. And then you're going to do a slit lamp exam, focusing on that anterior segment, so looking at the iris, the pupil, the lens. Now, if it's a high-speed injury, then you'll want to request a CT scan, just to ensure that there's nothing that's inside the eye now. And then if the patient presents with a decreased visual acuity, you're going to suspect that there's a more severe injury. All right, so if there is, the eyeball is penetrated with that foreign body, you're going to send them off to ophthalmology. Your superficial foreign body, you can send them to us in optometry, and we'll take care of them. And then once we remove that foreign body, we'll go ahead and prescribe antibiotics, just to ensure that there's no secondary infection. My go-to is going to be your fluoroquinolone, in particular your moxifloxacin, or Figamox. So now intraocular, it's inside the eye, foreign body, will produce eye pain, decreased vision. For some, they may not experience any symptoms at all, but most of my patients that I've had will experience some level of pain. If you ask the patient, what were you doing prior to experiencing, say, said symptom, they typically will have a very specific history. I was hammering, I was grinding something, weed whacking, whatever it may be. But there's usually a history that will support the symptoms. All right, signs. You may see actual penetration site. You might have some epithelial edema. This is a big one, an irregular pupil. Right? Normal pupil, nice and round. Intraocular foreign body or some sort of penetrating injury, that pupil will now look like a teardrop. All right, so that peak to that teardrop points at the direction of the site of injury. All right, so teardrop pupil, the peak of that pupil is pointing at the site of the injury. You can have some anterior and posterior segment inflammation, vitreous hemorrhage, decrease in intraocular pressure, as well as decrease in vision. That lens could also be dislocated. Now, because of that pupil irregularity, you might have anisocoria, so a difference in pupil size. Or you can have some deposit of iron in that tissue. So here's an example of that teardrop pupil. Right? So the peak, that point of the pupil is going to point in the direction of where that penetrating injury. Right, same thing right here. Injury site is going to be down here. Peak of the pupil. So peak of the pupil right here, site of injury is down here. Here's another example of it. And you can have that foreign body inside the eye, so that black speck that you see. Here we're warning some gross pictures. So obviously a penetrating foreign body.
Whoops.
There's also some rust that's developing on that cornea.
How long are we?
And then here's another one.
See.
Again, patients, don't send them to optometry. We're not gonna do a whole lot for them. Send them off to ophthalmology. And then here's another one. And the note from this is that that penetrating object is a pencil.
Choker?
Alright, so good history, you wanna know what the makeup of that foreign body is. You wanna do a complete ocular examination. Dilate that pupil so you can see if there's any retinal involvement. And definitely a CT scan for these patients. So on the slit lamp, the transillumination defect, so when you guys come over and sit behind that slit lamp, we'll show you. When you're doing that little beam cross section through that pupil, you shouldn't see any red light bouncing back at you, right? If there's a hole, you'll see a red reflex coming through it. So this is basically saying that you want to look at that eye if you're using a slit lamp and seeing if there's any red reflex in the areas that should not be there, right? So the transillumination defect. Like I said, refer them off to ophthalmology. Getting them there, you want to protect that eye, right? Do not remove that foreign body. Just secure it, stabilize it, and then send updated tetanus shot, IV antibiotics. Right, cyclophagic agent will help reduce some of that pain, especially if there's iris anterior chamber involvement. So it mobilizes that iris. Right. And then again, removing that fade will remove that foreign body. Alright, so blowout fractures. There's two different types, direct and indirect. Right, so direct is actually involving that orbital rim. Indirect is a compression of that soft tissue, and that force pushes up against that orbital wall and then fractures it. It's a big difference. Direct involves the orbital rim, indirect does not. Alright, so symptoms. There's definitely a history of some sort of blunt trauma. There's going to be pain with eye movement, some double vision, and then swelling of the lids. Right, so you want to make sure you tell patients to be very cautious when they need to sneeze or blow their nose. The increase in pressure can exacerbate the situation. Right, so extraocular movements are restricted. You might have anophthalmos, so the opposite of proptosis. So the eye appears to be sunken in. They can pinpoint tenderness and sometimes some numbness or tingling of the upper lip and cheek. Alright, so blowout fractures. So if there's muscle entrapment, they are going to experience pain on eye movement. Right, so this is where you're telling the patient to look up, and that left eye, in that left picture, that eye is not able to look up. So they're going to experience some pain and then double vision because both eyes are not reaching the same point in space. Right, the right side, the right eye is affected. So this is the left eye involvement. It's a little bit lower. It's a two-dimensional picture, so it's a little bit harder to see. But there's probably a little bit of anophthalmos going on as well, where that eye is kind of sunken in. It's a picture of what a patient may present in the office. And then a scan. You can see that the two eyes are not along the same plane. This one here is sunken in. Alright, so your workup, full ophthalmologic exam. Right, you're going to measure the EOMs, so having the patient follow an object and seeing if they're getting that full extensive eye movement, and if there's pain on eye movement. You want to rule out if the globe is ruptured. You want to examine the orbit for crepitus. Do we know what crepitus is? Yeah, so it's off that you can palpate around the orbital space or around the eyes and feel for that popping, that cracking, feel and sound. You want to measure the intraocular pressure. And then you want to look inside the eye to make sure that the optic nerve is not damaged. Right. CT scan will definitely help in pinpointing which bone is affected. Right, so these patients, again, you're going to refer them off to an eye exam. Typically, the three that I've seen, they came to me first and then I sent them off to ophthalmology. So you can alleviate that middleman and send them directly to ophthalmology, but you won't be in the wrong if you send it to us first. Alrighty, and hyphema. So hyphema is a blood collection in the anterior chamber, right? The degree or how much fluid or blood you see will indicate how severe that trauma is. And it may require ophthalmology to some sort of eye care provider should lay eyes on the patient, right? So we know that an 8-ball hyphema, right, is an urgent issue, right? An 8-ball is that complete filling of the anterior chamber space with blood. This is usually due to some sort of injury to the iris or the ciliary body. So I think, I don't know if I talked about it yesterday, but my patient with the shingles or hanging shingles got himself, he ended up with an iridodialysis, meaning the iris ripped away from the root of that structure. And so when that happens, it causes bleeding in that area, and so the patient also had a hyphema. Right, injuries to your sclera can cause a hyphema. And this can also occur spontaneously. Talk about retinoblastoma, leukemia, another form of cancer, or some sort of body disorder. Now, in a patient, you do want to make sure you rule out that there is some sort of abuse going on. All right, most of these patients will report that there was some sort of trauma that occurred. Right, but this can also occur from iris neovascularization. Pain, blurred vision, red eye, typically is a complaint. Now, if you have red blood cells that are floating around in the anterior chamber, the nomenclature is a microhyphema. And so it may, most of them will sit down at the 6 o'clock position, but just understand that if a patient is positioned a different way, that blood will pull in that direction. You might have a little bit of redness of the conjunctiva, and you may have a sluggish or a peaked pupil. Now, for my patient with that iris injury, a change in intraocular pressure will occur. And this is typically an increase in that pressure. And then here's a picture of the hyphema, right? So that red blood collecting down at the bottom of that anterior chamber. There's a little bit more. I'll say it's easier to see in a patient who has a light colored eye versus dark brown eyes. So here's another one down at the bottom. Alright, so taking a good history is important. You want to check both eyes, not just the eye itself, but also the area around the eye. Measure their intraocular pressure. You want to avoid manipulating aggressively that eye, right? So you don't need to touch or push on it. Do not touch or push on it. You can measure the percentage of the hyphema in that anterior chamber. I don't, unless if it's significant where it's passing the visual axis. Alright, so if you're suspecting an orbital fracture or any type of intraocular foreign body, you want to consider ordering a CT scan. And then screen for sickle cell for your African American patients. Alright, sending them to an eye care professional. Right, so it can either be with me, optometry, or ophthalmology. And then in the meantime, until they see an eye care provider, you want to make sure if they are laying down that they do lay down with their head elevated, so it pushes that blood down and settles towards the bottom. Right, it won't affect their vision too much. Right, so we are going to avoid aggressively manipulating that eye. So we are not going to patch that eye. You can put a shield over that eye just for protection so that they don't inadvertently rub their eyes, but no patching. Right, you want to immobilize that iris, so a cycloplegic agent. Avoid aspirin or NSAIDs if you can. Right, pain meds, and then you're going to treat that traumatic iritis if it's present. All right, your lid lacerations. So you're definitely gonna be concerned if there is a globe or orbit injury. There's usually a history of some sort of sharp trauma to the eyelid. They're gonna complain about pain, possibly with foreign body sensation, and definitely tearing. Alright, so signs of a lid laceration, there's a laceration through the lid margin. You can have some injection of the conjunctiva, and then you can have that fatty tissue that is exposed in the orbital space. So some fun pictures. There's a little laceration. Right here as well, along that lid margin. This one is down on the bottom lid now, and definitely you worry about the lacrimal system being involved. Lots of lid laceration. And this is the last of it. Okay, so a complete eye exam, you want to dilate both the eyes so that you can rule out any type of injury to the optic nerve. You also want to rule out any ruptured globe. Like I said, in the laceration of that one picture where it involved closer to the medial canthus, you start to worry about the lacrimal system being involved. A CT scan if the globe is involved, so that you can rule out a fracture or any type of foreign body that might be there. And then you want to evaluate that lid function, right? Because if that upper lid is lacerated, you worry about ligator muscle injury. Alright, so this patient will get tetanus shot, antibiotics, and then you want to refer these patients to ophthalmology so that they can repair it. For the minor ones, I guess if a family practice or active duty provider feels comfortable, they can go in and repair it. But I would definitely send them off to ophthalmology as soon as possible. You want to restore and preserve that lid function. And from a cosmetic standpoint, you want the professionals taking care of that. Alright, the last of our conditions. So orbital compartment syndrome, right? This is an ocular emergency due to increase in intraorbital pressure that can result in ischemia and irreversible vision loss. So your orbital wall is rigid, right? It's hard, there's no give. And if there's bleeding or fluid that enters that orbital space, the walls won't flex, and it can cause a lot of pressure, which would lead to the eye protruding forward. And that proptosis can cause the optic nerve to stretch and become damaged, ultimately leading to vision loss. And so the initial treatment is to relieve that pressure. And to do so, you would do a lateral canthotomy. Right? So I have never done this, nor do I ever want to do this. But you would prep that area, anesthetize that lid, irrigate it, make sure it's nice and clean, and then you're going to use a hemostat. So you're going to clamp down on that lateral canthus, so the outside canthus. Once you remove that hemostat, you're going to cut that lateral canthus with a blunt tip scissor. It's going to expose this tendon. And then you're going to use that same scissor and you're going to cut inferior lateral canthal tendon. All right, that creates a little bit more space for that eye. What I've been told by ophthalmology is that tendon, they can repair it. So that's not a big concern. The biggest concern is that you don't want that optic nerve to be damaged and then they lose the vision. once that's done, there's some IV meds that they would give, and then consider also lowering that intraocular pressure. I don't know if y'all have heard or seen the show The Pit on HBO. Not that I'm promoting anything. But there is a case in there that they actually did a lateral panthotomy, and it is pretty darn accurate. But if you want to see the real thing in action, there's that YouTube link there. It's about a 10-minute video, and it is up close and personal with that patient. So that procedure being done. All right. Any questions? Better than retina? Better than glaucoma? Maybe better than neuro? All right. So understand the difference between your preseptal and orbital. That will definitely will show up to you guys before they show up to us in optometry. Right? The corneal abrasions, the chemical injuries, all that stuff is all anterior, and so you can see that quite easily. And there's really no like, if it's this or is it that. If it's an abrasion, it's an abrasion. A lot of times in the clinic there is a slit lamp on wheels, and I've been at 2 clinics where we had them, and family medicine, active duty clinic had access to it. If not, there you guys can get fluorescein strips and a Woods lamp, so it's a handheld blue lamp that you can go ahead and put the dye in and actually look at it. My choice in antibiotic is your fluoroquinolone, so Bigalox or ofloxacin. Definitely, so if you are concerned with the cause of that injury being from like a vegetative object, so like a tree branch, a shrub, whatever it may be, a fingernail, because you never know what's underneath that nail bed, or if it's a contact lens patient. Right? You want to make sure you treat it aggressively right off the bat. Polytrim and is there. I've seen it a lot from family practice, prescribing it even from the ER. But a lot of times it induces a little bit of redness, a little bit of pain that patients are just not a fan of. And so, like I said, I tend to lean towards your fluoroquinolone. All right. The compartment syndrome, some crazy stuff. I have never seen it in the clinic, but definitely it's been showing up a lot more in literature, especially in the military setting, just because of the jobs that we do when we send our members downrange. Right, and you guys are the first one that's going to see them, and you might have to do this, right? But otherwise, it's a pretty straightforward lecture. Okay. All right.